Well, hello everyone and welcome back to another ResearchWorks episode. I'm Dana and unfortunately my friend Ash is not well and not here with us today, so I'm flying solo. But I feel like with the guests we have today, we'll have plenty to talk about. Ash, I hope we do you proud. It's feeling like a little bit of an upper limb kind of series lately, and to really talk about the research in the space, we have the one and only Professor Roslyn Boyd joining us. Hello, Ros.
Hello, lovely to be here.
Oh, it's so wonderful to have you here. I think we've been trying to coordinate this for quite some time now. We've caught up at conferences, but I feel like this has been the perfect way to have a chat because we're going to be talking about a study that's a really big study that has occurred here in Australia, and it's a recent publication. It is titled Randomized-Comparison-Trial of Rehabilitation Very Early for Infants with Congenital Hemiplegia, and this was published in the Journal of Pediatrics in 2025. So I'm sure everyone already knows who Ros is, but I'm going to go ahead and introduce you to everyone anyway, because there's a lot to what Ros does. So Professor Ros Boyd is an internationally recognised leader in paediatric neurorehabilitation and cerebral palsy research. She is the director of the Queensland Cerebral Palsy and Rehabilitation Research Centre at the University of Queensland and has dedicated her career to advancing early detection and intervention strategies for infants at high risk of cerebral palsy. With expertise in neuroplasticity, advanced brain imaging and clinical trials, she has led multiple groundbreaking studies, including this one, the REACH trial, which explores optimal early rehabilitation approaches for infants with unilateral cerebral palsy. Passionate about translating research into practice, Professor Boyd's work continues to shape evidence-based therapy for children with neurodevelopmental challenges worldwide. And see, this is why she's a leader in our field. So it's such a privilege to have you here, Ros. And, you have mentored me through my seasons of being a researcher. And so it is such a thrill for me to speak with you because I've learned so much from you. And it kind of leads to the icebreaker question that we have today, which is normally Ash's she has great questions, but I think this is a pretty good one because it speaks to the breadth of your experience, Ros. So I'm just wondering if you can tell us, over the last few decades, how do you feel that the research scene has changed over time? What would you say to that?
Oh, thank you. Dramatically.
Yes.
When I consider how I started out, you were the handmaiden to the doctors and you had to do the research that they wanted to do. And now I think allied health professionals, having gone on and got their PhDs, are now treated as equal partners and leading a lot of the research in cerebral palsy, which is fantastic. But I think it's a really multidisciplinary collaborative effort now. But I think the really exciting thing is that allied health professionals have led the way in some of these big clinical trials.
Yes.
So for the first time ever, we have 2 clinical trials recently that have shown effectiveness of early intervention.
Yeah.
So that's pretty groundbreaking because when I came back from London 30 years ago, the neonatologist was saying, physiotherapists in our NICU over our dead body. So I said to Alicia Spittle, I think you better do your PhD and then they'll start to take us seriously. So Alicia's gone on to do wonderful work.
Yeah.
But, then we were doing research that was designed by, I was working with orthopaedic surgeons. We were doing the studies they wanted to do. They weren't keen on randomized controlled trials. So now it's wonderful because I think most of us have the freedom to do the studies that we know need to be done.
Yes.
So we now have good evidence for very early detection in the first months of life.
Yep.
We have some promising evidence now for 2 randomized controlled trials that are showing effectiveness of early intervention. So I'm talking about this study, which showed that both groups improved with very early intervention, and also the recent study, which you should talk about on another podcast, Dr. Kath Benfer's study in India, which showed that early rehabilitation was also effective in large clinical trial.
Yeah.
So I think allied health professionals now have the opportunities to be equal partners, to answer the tough questions, to drive the research and to make a difference for families because we don't want to just be answering questions that other people want to answer, but we also want to be able to make it practical and relevant to families and to clinicians.
Yeah. Gosh, Ros, that was such a great answer. I reflect on that and I don't think I would have known otherwise, right? The opportunity to seem like it was there because it's been paved before me because people like you have done it. And I think of what it's done in terms of the opportunity for a career progression or to be able to think critically and try it out yourself. I always thought it would be such a given, but it really isn't. It's been something that has been worked on for years, hasn't it?
Very much so. And I think there's a few promising things that happened. When I started physiotherapy, actually our head of physiotherapy decided to make the profession 50% men, 50% women at the University of Sydney at Cumberland College. So she actually reduced the pass mark for the men to get in. So it was quite funny. We laughed about it at the time, but there's been amazing people like Rob Herbert and Chris Marr and all sorts of people who've come on board and changed the profession now that it's a career path for both genders and that people have a real path towards development.
Yeah.
But I think the next thing was when I was in Melbourne and came back from London, physiotherapists being encouraged by their mentors to do PhDs. We had a large number of physios who all did their PhDs at that time, Julie Bernhardt, Janice Collier and others. And so it's really moved us all forward now in leading the research and working alongside. And I think that's been important for our career development.
Yeah. I'm so glad you told us about that because, I'm incredibly grateful. And here we are talking about some pretty influential research. And when we talk about research, we're talking about one article, one project, but it really is on the back of many, many, many other bits of research that have been put together by teams. And this one is no exception in terms of the team. If you look at the paper and the authorship, it's so representative of so many professionals we've spoken to before on the podcast. It is such a combined effort. And so really, really grateful for that. So let's get into what this is all about. I have so many questions for you. So for everyone, this is a bit of a summary about the REACH trial. So the REACH trial is the largest randomized comparison study to date investigating baby constraint-induced movement therapy and baby bimanual therapy in infants as young as 3 to 9 months of corrected age. The study found that both therapies significantly improved early hand function, but neither was superior, challenging assumptions about uni-manual versus bimanual approaches in early neuroplasticity. Interestingly, infants who commenced therapy before 6 months of age showed greater functional improvements, reinforcing the importance of early intervention. With direct clinical implications for therapists, this study provides crucial insights into therapy selection, dosage, and parental engagement in infant rehabilitation. So there's a lot to delve in there. But first of all, I thought let's take a step back and understand what was it that motivated you to do this study? What were the gaps you were trying to look for that you were trying to address? Like what got this started, Ros?
I guess through the previous studies, we've done a lot of upper limb rehabilitation studies with Leanne Saksuski's PhD, with the INSIGHT trial, with different unimanual versus bimanual approaches, the circus training, different dosages. We've done a lot of that, as had others around the world. And, Anki Eliasson and Sue Greaves were starting to work with infants. So we thought, well, we really want to be doing this at an optimal time of neuroplasticity. So the big thing has been identifying the babies early enough. Yeah. And so that now we have that not only the general movements, but we have other motor optimality scores that can help us with identifying early asymmetries of upper limb movement. We can start, and with other work that we did with Andrea Guzzetta, we can really optimise that time of when we commence. Yeah. Now, we'd like to start even earlier, but we need to know that we've got the right babies. Yeah. So obviously there was a lot of concern when we started. You wouldn't want to be doing constraint on a baby who didn't end up with an asymmetric brain lesion. Yes. So that's where we had very strict criteria for entry into the study. And then it was making sure that they had not only asymmetric hand function, which we're very grateful to the Swedes for developing the hand assessment for infants, because that's not only driven the entry criteria, where we found a 3-point difference was indicative of later asymmetries in hand function.
Wow.
But it also helped us to increment the study advancement at the right level. So in the important aspects of neuroplasticity being we've adopted that you not only want to start at the right level of ability, but you want to increment it, and you want to increment it in stepwise fashion at the right pace, not too hard, not too easy. And that's the work I learnt from Professor Mike Merznick when I worked with him from the California on neuroplasticity, is that it's not about the dose, it's not about how much you do, it's the level you work at and how you increment it. And I think the other thing we've really learnt from the study is about how we impart that knowledge to parents. And it's the coaching model, which is so important. And probably back in my early days, I was in London and I had someone called Sophie Levitt, which not many people would know, but she wrote a book on early child development. And the first session I had with her, she came in to mentor me. She said, don't touch the baby, let the mother do everything. Because the minute that you take over, you make them feel less competent.
Yes.
And I think REACH is a good example of how we've used that coaching, the model where the parents are more competent and they're delivering the intervention. And that's what's important. It's actually what they enact that's important.
Yeah. That feels like such a shift, doesn't it? When you look a lot at, traditionally how physiotherapists, how I was trained, which was over 20 years ago now, and it was all very much, my hands were on because we're used to doing stretching or passive mobilization, which we obviously know where that stands with when it comes to research. But it was so much about what we could offer as therapists through our hands. I even remember our shirts was like, use our hands to change the world or something like that when I was at uni. So, it's how we trained, it's in our thought process. What was it like in the study to sort of make that shift to kind of going, okay, it's the parents.
Yeah.
What was that process like and what did you guys do?
And what you're saying is actually correct. Back in the 80s when I was in London, I did the Bobarth course, was one of the last courses with Mrs. Bobarth, and it was like the master clinicians who had magic hands.
Yes.
So it was all about the therapist feeling very competent and able to change the baby through what she did.
Yes.
So thanks to people like Iona's work on the traffic lights, we know that it's actually not what the therapist is doing that is passive. It's actually what the baby needs to be active. So people like Anki Eliasson have really reinforced that.
Yeah.
And it goes back to the fact that we need to, and some of the therapists who've been around a while found this very quite difficult, that they weren't doing the hands-on. It was actually imparting it to the parents. It's hands-off.
Yeah.
It's getting the parents to work playfully with the baby and give the right stimulation to facilitate and encourage active hand skills.
Yeah.
So, it's a really different mode, but it's also been a very positive mode, I think. And when it came to COVID, our REACH families were totally ready to continue. They were, not only because we hadn't always done in-person home visits, our alternate visits were via Zoom. So that also made families in control because they were delivering the intervention and we were there helping and supporting and observing and coaching.
Yeah, sure.
Whereas, if you always did regular weekly home visits, sometimes the parents think, oh, well, the therapist should be doing it.
Yeah.
And in our work in India, they had a real problem with the fact that the therapists weren't doing it. They thought that wasn't effective therapy.
Yeah.
The parents thought, well, it should be the therapist doing it, not the parent. Yeah.
I can relate to that. Like I do a fair bit of work in Malaysia, and in the early days that I used to go there, it was probably like 2008, 2009. Parents would literally come in, bring their child. They usually have to carry their child, so no equipment. They bring them to you, they place them on the floor in front of you, and they're like, do something. And, I remember back then, well intended, but I would stand back and go, I don't know what I can do right now. The sense of expectation was so great because they'd come to you as a professional. And then what I did learn, though, from my colleagues in Malaysia is they didn't tend to call the physios. They called them teacher. And I thought, actually, that is a beautiful way of seeing our role. Like even just relabeling us as teacher, you kind of go, okay, my role is isn't just me putting my hands on the child. It's about my relationships with the people around the child.
Exactly. And what's really interesting now is when the babies from the REACH trial come back to visit our clinicians in the Queensland Children's Hospital and other parts, they say these parents are so competent.
Wow.
They know exactly what to do.
Yeah.
They don't need us.
Yeah.
They actually know what therapy, what the child should be doing, what they should be receiving, and they're really well supported and trained.
Yeah.
So they're totally different. And that's, to me, the most exciting part, actually.
It is, yeah.
Not just the trial, but that translation for families to feel that they've become more autonomous.
Yes.
They're able to make decisions to know what's the next skill my baby needs to learn.
Yes.
I know how to help them do it. I know how to work with them. That's the really important in part, I think, that translation.
What do you think about that in relation to cost effectiveness, which is always on, everyone's mind at the moment, when we're thinking about how does the dollar go further? And I know when they do the cost of cerebral palsy, for example, it's not just the direct cost, it's the well-being costs, it's the parents able to go back to work, it's their contribution. Like, this must be a really good thing when you think about long-term economics. Yes, it's sort of complicated though, because I actually listened to a podcast from a very senior neonatologist recently, and Lex Doyle, who we did the Vibes study with when I was in Melbourne, Vibes Plus, and he sort of said, how hard it was to have the cost of a physio and a psychologist going up to deliver therapy in the home, and maybe that wasn't a cost-effective model. And yes, now they're moving towards web-based telehealth, that sort of thing, which is true. But, the costs of delivery of allied health interventions, I think we need to be, it's not about the amount of times we see them. It's not about the frequency, which I find the Americans are very fixed on dose at the moment. It's about what we impart and how they translate that. What do they actually enact? Yes. So for having what they've learnt, how do they then enact that into their child's everyday life? So that's going to be more cost effective in the long run. Yeah. And I think parents are then going to feel stronger and better able to cope in their parenting skills. Yeah. So things like the NDIS are a little bit crazy because it's encouraging parents to sign up for weekly therapy, to use up their whole plan, and to get as much intensive therapy as possible. But that's actually not the point. The point is, what does that family from their sessions with a therapist translate into everyday life? Because as Professor Merznick said to me, Mike Merznick said, it's not what you do in those sessions, it's what they do every day. Yeah. So if you're a musician, you practice frequently every day. You don't just do it once a week. Yeah, that's right. You don't do it only when you're with your conductor. You do it in your real environment all the time. Yeah, no, that's a really good point. Well, let's get into this methodology. I love looking at the methodologies that you've been involved with because, like you said, RCTs in this area, it was initially like, what are you doing? But now you've done many of them. So can you just talk us through the structure of this RCT? And, over to you because you're the expert in this by far. Yeah, and I think they're easier than people think. Everyone was a bit scared about RCTs when we did the HIP study back in the 1980s and 1990s. They were all, but luckily, having worked with Kerr Graham, he'd done a lot of RCTs in botulinum toxin. So the model was there for a clinical trial of an intervention that was a new novel pharmacological intervention versus control. So when we're doing therapy interventions, we need to consider the same principles, but we've got to take care of the control group and make sure that they are not feeling lesser in their support. Yeah. So we've moved to lot 2 waitlist control so that they're going to get the new intervention anytime. However, when it came to babies, the ethical consideration of withholding treatment was a big one, which is why we went to the randomized comparison trial. Yeah. And not everybody agreed with that, but the ethics was a big component because you couldn't find out a baby with a stroke or who had an early asymmetric brain injury where you would withhold treatment. Yeah. But then you'd have to say, well, what does that comparison look like? Is it sort of a conglomeration of different things and then it's hard to compare? Yeah. Is it a different dose, so the dose is going to make the difference? So that's why we went for the randomized comparison trial, which some people have
kind of said, well, you didn't really do a randomized control trial, so it doesn't tell us anything. But in fact, it tells us that equal doses, equal strategies, equal approach of either intervention is effective.
Yeah.
And so that's really important. But I don't think we're going to be able to run randomized controlled trials in the high-income countries in early intervention anymore.
Yeah.
Because it's going to be impossible to have a control group, and it's going to be impossible to have a group that haven't received very appropriate, good therapy. So we're not going to be able to withdraw that.
Yes.
So I think this is our last.
Yeah.
These are our last chances for randomised controlled trials in high-income countries. It's going to have to be in new low-resource settings, which is why the Indian study is so important.
Wow.
Because it showed what a difference we made in mild to moderate CP, in improving their outcomes with the not really high touch, but through a peer support program that we made a difference, or Kath Benfer made a difference in her team.
Wow, that's an important consideration, isn't it? So within this trial then, can you talk us through like who were these infants? What was the inclusion criteria, I suppose, is the main question.
So the babies all had to have had an asymmetric brain injury on an MRI or cranial ultrasound. They had to be high risk of asymmetric cerebral palsy, so absent fidgety or a lone hind score on low hind below the CP cut points. But then the very important ingredient that we added was that they need to have at least a 3-point or more difference on the hand assessment of infants. So that we were very grateful for the work that the Swedish team, that Lena Kumlund-Sondhammar did, and others on developing that tool and identifying that if you had more than a 3-point difference, you were likely to have an asymmetric hand development. Because at 3 months, it's still not always clear.
Yeah.
And we did have to expand the recruitment up to 9 months because it wasn't always clear if there was that 3-point difference even by 6 months.
Right.
Yep.
Okay.
But we will change that inclusion criteria in the next study, but we'll get that to that later. Yep.
Okay, well, that sounds exciting. All right, we'll make sure we go back to that then. So in terms of the actual intervention and the assessments that took place, do you mind just going through that in a bit of detail? I mean, people can look into the paper for that as well, but just to go through the breadth of the assessments that you did have.
So the assessments were validated tools that we had at that time. Some challenges with that. The hand assessment of infants is the best early tool for upper limb development.
Sure.
That follows on to the mini AHA and later the AHA. One of the challenges is, though, that the hand assessment of infants does not link directly to scores then on the mini AHA.
I see.
So that's a challenge. Also, we didn't have it at the very beginning, so we didn't have always have the hand assessment of infants, so we did change the primary to the hand assessment of infants. We originally started with the mini AHA.
Okay.
But that's and then we had other measures of cognition, the Bailey, and we had other measures of emotional availability, and we had work on parents just on the DAS, that's stress and emotion.
Yes.
So we had a comprehensive test, but they were very focused on what would be the outcomes we would expect to receive. So we took note of what Anki Eliasson said to us. You only gain what you train. So you don't need to be looking at other measures of participation or quality of life or things that aren't going to be impacted by early upper limb intervention.
That's a good
so
point.
you do need to be mindful of burden on the families, but you can't necessarily expect to have a change from activity limitations to participation. And I think a lot of people forget that. Plus, there's not very many tools on participation that are appropriate in this age group.
That's absolutely true. No, that's great that you run through that. And that's so, that's it's a point, you're so right. It's something that you do need to remember, that you only really want to be assessing things that you know that the intervention, because it's a task-specific intervention. So your assessment, therefore, also needs to be very task-specific in a way if you're going to, look at the changes. And what I also noticed in your paper as well, and I wonder if you can talk more about this, is that you did have some brain imaging as an exploratory outcome, which I always think is very interesting. Not just relating to this study, but as a whole, what role does neuroimaging play in understanding, like, therapy effects in early CP? Because I think that's so interesting.
Yes, sadly, not as much as we'd like.
Yeah.
It's a challenge to get early neuroimaging in babies
Yeah,
in the neonatal period.
Sure.
In many places, only in very large tertiary institutions, and not always babies. If they've had a stroke, yes, they're likely to have an image taken, or a hypoxic ischemic encephalopathy. A lot of preterm babies won't have imaging, and that's quite understandable because of the resource. But so sadly, in many situations, you won't get an early MRI. And then the problem remains that the quality of the MRI, so it needs to be high field, 3 Tesla. It needs to be the correct sequences if you want to understand changes in the brain that might be in response to some sort of intervention. So we're talking about high diffusion imaging with the Hardy model. We're talking about functional MRI is not appropriate because you can't do a functional task in MRI in babies. So, in my PhD, I did functional MRI and I did specific tasks related to hand tapping, related to see if that was related to changes in the Bold effect in the brain, the blood diffusion, to show which part of the brains were activated. But it's a little bit more complicated than that. But then again, we had the problem we would have liked to have done follow-up MRIs at 2 years of age to see if there was a change in brain structure, brain microstructure on diffusion imaging. However, most clinicians, quite rightly, don't want to put a baby through an anaesthetic at the age of 2 if they already know they've got a diagnosis of hemiplegia or they've had neonatal imaging.
Sure.
And neonatal imaging doesn't correspond well with later imaging at 2. There's quite a different way of analysing the data. They're very different brains. So there's a lot of complexities there. But I think what it tells us is neuroplasticity is about brain function. So if the function changes, what's driving its changed? So you could probably say by result, there has to be neuroplasticity if you change function, it's over and above what natural history would be.
Yeah, no, those are really good points. And I think it's something that's so important to consider because it is, as researchers, yes, you want to assess because there's very interesting things to assess for sure, but there is a burden and we need to make sure that's the right kind of assessment as well. And it's not as simple as saying, let's just do some imaging. It doesn't quite work that way. So that's really great that you've pulled through that information. Now, before I go into the results, I thought it'd be really good just to quickly talk about the intensity or dosage of practice for these infants, like what was actually delivered for Baby-CIMT and Baby-BIM.
So it was equal. And as Anki Eliasson pointed out very early on for us, because she said it needs to be at the right level for paying close attention. So what Professor Merznick said, neuroplasticity about optimising, the dose needs to be optimised to the baby being able to pay close attention.
Yes.
So it's in small doses to start with frequently through the day. Yeah. And that changes as the baby develops because their concentration is greater because the baby needs to be actively involved. And so it's active, it's not passive, and the baby's engaged and the baby's playing in playful ways. So the dose is not actually the really important part. It's actually what they were doing. So it's the mode, the content, what's hand skills and the incrementation of those hand skills in level of ability, the motor learning that's occurring, that's most important.
Yeah, sure.
So that was very carefully graded and described and trained to the therapists. They would do a hand assessment of infants to get an idea of the baby's level of ability in the beginning. Were they just stabilising with their impaired hand? Were they able to grasp or not? How mature was that grasp? Were they able to manipulate within their hand? Were they starting to do some bimanual work? So this is all the important bit. And in-hand manipulation, of course, is way beyond this age group. But just as an example, you need to make sure that it's the incrementation and the content of what you're getting the baby to do. So that's where Susan Greaves' work with the type of toys that you choose is so crucial and very important because the toy will dictate what sort of activity that the baby's going to attempt to do. And then how the parent presents it to them. But this is how you're going to increment the intervention.
Yeah.
So dose, I keep saying, is actually not so important.
Yeah.
It's actually about what they're doing.
What you're doing.
And how much they advance, how much it's incremented. Yeah.
No, those are just wonderful points. And I just reflecting when it comes to the role of the therapist again, it is actually, there's so much involved in it. You know, when you think about the value that you add, you spend a lot of time thinking about the environment, thinking about the modifications and the changes and the increments. And that's where that high level thinking really comes through, as well as then coaching with parents as well. So, yeah, it's lovely that you've been able to describe all of that for us.
And I think we were very fortunate because Anke Eliasson had done a lot of work on Baby-CIMT. Sue Greaves had done a lot of work with others in the team in working on Baby-BIM. So we had very detailed manuals for the therapists. We did detailed training at all the sites.
Yes.
And we did regular therapy catch-up. So we had a sort of practice group that worked, and they all met together, the therapists.
Yep.
They gave up case studies. They'd share the load. And we let them lead that so that they became sort of a community of practice.
Yes.
And so they could support each other in how, if they had a difficult case, particularly some of the ones where with dystonia or who had more challenging behaviour.
Yeah.
But on the whole, in fact, the engagement for the babies was really very good.
Yeah.
And sometimes it was more around, you know, there was a lot of other things going on for the family, and was that more challenging?
Yeah.
And interesting, when we show our workshops, which we've mostly done overseas, we showed that the case studies for babies who started older, that's where it was more challenging because they were more lateralised. And if we were trying to do baby bimanual, it was more challenging to get them to engage with both hands.
Right,
so timing is also very important from that perspective.
Yeah, sure. Well, on that now, let's get into the results. Obviously, we've spoken a little bit about them. There's a lot of clinical implications that are derived from those results. So, look, one of the main key findings, as we've spoken about, is that neither was superior. Now, were you surprised by that result? What were your thoughts?
Not at all.
There we go.
Not at all. We probably within the first year, we were pretty sure that that's what the result would be.
Yeah.
And we think that's actually a really good thing.
Yeah.
Because I think it gives clinicians choice. It gives parents choice. Either mode might suit certain babies more than others.
Sure.
And some of us have been very concerned about the emphasis on Baby-CIMT as being the be-all and the end-all.
Yes.
And we know that that's not the case. That Baby-BIM is equally effective and probably at an older age is even more important. Because babies only do unimanual actions for a limited period of time.
Yeah, sure. Yep.
And if they're going to have an effective hand, they need to have bimanual hand use.
Yeah, yeah.
So that's sort of why we think that, the results weren't surprising. It might have been disappointing to some, but they're not really reading the results correctly because they did have an improvement on the hand assessment of infants, both groups equally, and they have made substantial gains. I think we need more studies. That would be helpful, but we'll have different ideas for some of that as well. Yeah.
Another interesting finding as well was the timing. Can you talk to us a bit about that time? You sort of did allude to that earlier about, infants who are a little bit older. There's more, laterality as well. So can you talk us about, when's the best timing according to what you found in this study?
Yeah. So it wasn't a really strong result, but it was a signal that showed us that was significant.
Sure.
That the group who started before 6 months had a faster hand development than the group who started after 6 months.
Yes.
Now, this is a little bit more complicated because when you read the literature and you understand the hand assessment of infants, it's not just a straight curve. It's a bit of a parabolic curve. So there is quite a lot of hand development that happens early on. So it's not a really strong finding, but I think it points to the direction of other things that that those babies who started later were more difficult to get them involved, particularly in bimanual therapy, and also to have them engaged in constraint-induced movement therapy when they were incredibly lateralised. Yeah. Probably their sensory system was dissociated, that they were getting feedback from their ipsilateral projections and not their contralateral.
Yep.
So, those sort of those reorganisation had already occurred.
Yes.
So the early work that Andrea Guzzetta's done on early hand movements and looking at when we start to develop and drive the system for early hand skills is really important. So it is at about 3 months that we move from the general movements to the volitional movements. We start to reach towards objects. We start to do hand touching, toy touching, face touching. So this is when the system is starting to drive purposeful movement.
Right.
So as the corticospinal system is fairly much wired by 6 months,
yes,
it makes sense that the earlier we can start,
yes,
the better. Our challenge is identifying those babies early enough with their early asymmetric brain lesions.
Wow, that's quite a target. Like, it's getting closer and closer in terms of its precision, isn't it? Really targeted. They call it precision medicine, I suppose. Is that, it's knowing the conditions and the intervention to match. I'm curious about your results. Was there anything that you found that was unexpected through what you studied?
Not especially, but I must say we didn't expect that earlier babies would have that faster development than the later babies.
Sure,
that was a bit of a surprise, actually.
Yeah.
Which is a pleasant surprise.
Yes, good surprise.
And some of the team weren't sure that it was really strong enough to report. And I said, I actually think this is a really important signal that we need to report, because whilst it's not the main finding and it was a secondary analysis, I think it's an important, very important thing for clinical practice.
Yes.
So we need to continue to work towards that very early identification of babies who are high chance of an asymmetric brain lesion, who are high chance of a unimanual sort of ability, and that it's safe to do either treatment.
Yes.
Because remember when I said in the beginning people were really worried about constraint?
Yeah.
There's no problem with doing short periods of constraint.
Yeah, sure.
Not 24 hours constraint, and certainly not with a rigid arm cast. We're totally against that. So I'm sorry the Americans still do that, but it's not necessary, and you can achieve the same benefits with small doses of constraint or bimanual in the optimal way without a rigid constraint. Yeah.
That's fantastic. I still distinctly remember I was a very young physio back then, and I met this very proactive mum who raised it with me and said, we're going to go and get a cast on our child and do constraint. And I'd never heard of it before. And to me, I was like, whoa, what is this? And, this gives such clarity, doesn't it, in terms of what you need to do, what you can do. Yes, this gives us choice. You've got Baby-CIMT and you've got Baby-BIM on offer. What would your advice be for clinicians when they're making their choice, especially if they're perhaps maybe not as clinically experienced, they're quite new to the field, and they've seen a child in their caseload and they've got this child that's presented in front of them? How would you advise them to move forward?
Yes. I think we put it in a general fashion in the paper.
Yeah.
And I can give you some of my own thoughts, but I think most of us would say it's a choice between the therapist, their skill set and their confidence with either approach, and with the parents, their choice of goals and where the baby's at in their level of development. So is their hand function at that early unimanual reaching and grasping, or is it where there should really be at bimanual activity? So, I think there is a developmental component to this and also a cognitive component. Does the baby understand when you're wanting to get them to use both hands in an activity? How are you going to impart that with just the toys or with action observation, or how are you going to get them to do that? Whereas constraint is sometimes a lot easier because you're putting a constraint on their good hand, so therefore encourage that they have to use their other hand. But some babies might be too severe and constraint will potentially not be a positive experience.
Yes.
Because their impaired hand is at such a low level. They're only stabilising.
Very frustrating.
They're not able to grasp, and they're probably not the right case.
Okay.
So I think it depends on the baby's level of ability in the beginning and their cognition and their ability to follow and observe and play with toys and observe actions, and also the parents' sort of willingness to work with a strategy, and also the therapist's confidence. So it's a combination of things.
Yeah. And you've mentioned earlier, obviously, there's a lot of work in your network, work in India, for example. So countries, low resource settings, are there any specific considerations for therapists working in those settings when they're working with these children and thinking about these interventions?
Yeah, so we've been very excited to do both baby constraint and baby bimanual in India with our project that Kath Benford did in 156 babies at high risk of CP.
Right.
We're also doing it currently in Georgia, in Eastern Europe, in our Born to Get There program.
Wow.
And we're doing it in Sri Lanka with our team. They're doing the LEAP study. So constraint and bimanual is part of our LEAP program, which is about early intervention using active motor training with motor learning principles, and also parent coaching is a very strong component. So yes, and in these low resource settings, it's not always a trained therapist who's delivering the program.
Yeah.
So it shows you that in the Indian study, it was delivered by a peer-to-peer person, someone who might have lived experience of cerebral palsy, had a child themselves, could be a health worker. So we called it the Chinese whispers. The trained therapist was training that peer worker to go to the parents and work with them in the home. And that was very effective because she was from their community. She was accepted.
Yes.
She was able to be understood and listened to. Same with our Indigenous population with LEAP in Australia, very important that they have someone coming into the home who they trust and will work with, which is why there's that model.
Yeah.
But I think the bottom line is that it doesn't have to be a highly skilled therapist to deliver these programs. That's what's really encouraging, I think, for low resource settings.
The
that
translation.
We can provide very effective therapy by training parents, not necessarily through highly skilled therapists, but having skilled therapists coordinating and training and being involved. But it's quite possible to really maximise that and translate it across large populations. Wow. The really exciting thing, we were yesterday talking to our team in Kolkata who've continued the ELITE program beyond the randomized controlled trial. And at the Asha Bhavan Centre, they have screened over 1,300 babies in the last 2 or 3 years.
Wow.
And they have now completed LEAP program in over 400 families.
Wow.
And so absolutely amazing with that same model.
Yeah.
So the implementation with limited resource has been really amazing. And this is what we need to be doing. It's not for the high risk, high resource countries where we can work specifically, we can provide the right interventions at the right dose. But this is where we can really have the impact in making a difference.
It's the health equity
countries.
Piece, isn't it? It's really, we're discovering this, we can train, we can support. That is so incredibly encouraging. Now, you alluded to work that you have, you already told us about some of the work that's already happening, which is extensive in more countries than I realised, Ros. But what is the future for research in this space? You kind of alluded to a few things that are sort of happening, things that have maybe evolved from this particular study. What are we looking forward to, I suppose?
I think what we're really looking forward to is a couple of things. Really identifying those babies who need help very early. So we're now talking about the first weeks of life.
Wow.
So we want to understand from the early motor optimality scores, from the early general movements, what are the features of asymmetry, what are the features of hand skills. We're also picking up the babies with cerebral visual impairment at 3 months.
Yeah. Wow.
So through that early screening and surveillance, we're picking up the babies and triaging them to the right intervention. So who's going to have, with the motor optimality score, we can now tell babies who are high chance of non-ambulant CP. We can also tell the ones who are more like, we're starting to get a handle on the asymmetries that might have hemiplegia, but that's not always so clear, but combined with a good MRI, that could be clearer. And the other important group, I think, is not just about picking up cerebral palsy. It's picking up these other suboptimal babies who aren't typically developing, who don't have severe CP, but actually have mild forms of CP or have other adverse neurodevelopmental outcomes.
Wow.
Now, this comes from our Indigenous work, because the First Nations community said to me when I went to visit them in Rockhampton, they said, at Warrabinda, they said, we know about that thing, cerebral palsy. We're much more worried about autism and that fetal alcohol problem. So we thought, okay. So that's why we shifted gear in our QEden network and in Carly Luke's PhD and in the Indigenous work to not just pick up CP, but also pick up these other adverse neurodevelopmental outcomes, because a lot of the same interventions will be very relevant for these babies.
Yes.
So that's why we've expanded the LEAP program to incorporate these babies who would not normally be picked up until school age.
Wow.
And as my clinicians in Darwin tell me, and then I see them at Donvale when they're 12 or 14 and they're really in a bad way.
Wow.
Whereas if I'd picked up that atypical baby much earlier on, I could support that mother with the right support and the right coaching. Maybe the outcome could have been different.
I think
so that is an equity issue, as well as understanding the early brain injury.
Yeah.
It is about equity of what we're delivering.
Yeah. It just speaks to the value and importance of doing research and how one research study, it never ends with one research study. It leads to the next and the next, which is why I was very keen to hear what you've got coming next, because this study was a big study over many years, but I can imagine as it was going along, you're already seeing where it could fit and what it could impact for people.
Yes. So we're very interested now. We're doing the ePNO study, early prediction of infant neurodevelopmental outcomes. So that's at Royal Brisbane in Brisbane, Monash in Melbourne with Rod Hunt and his team. And we're just about to start also in Townsville. So we're doing the very early biomarkers. We're doing not just early neuroimaging and early EEG, which is very promising. We're doing the early general movements on the GMOS and other tools. We've been to Rome and learnt from at the Gemelli Hospital with Domenica Romeo and Daniela Ricci about the early vision assessment so that we can pick up these babies extremely early and we can follow their path and then we can get them to the right intervention at a much earlier time.
Yeah.
So that's the sort of proposal now because we still don't have effective interventions before 3 months. We know that we want to start before 3 months, but first we want to have the right biomarkers to say, so we're doing blood biomarkers, we're doing genomics, we're doing early tools that will help pick up those babies most at risk of an adverse outcome.
Yes.
And then we want to get them to the right interventions. And those interventions, again, won't necessarily be a therapist being delivered something to the babies. As we know from our work with Whittingham, the most important active ingredient is the parent.
Yeah.
So it's the parenting support, the parenting skills that are most crucial. So babies, parents being able to read their baby's cues, to work with their baby, to coach their baby from early on.
Yeah.
Yep.
Gosh, that's exciting. Thank you so much for sharing that with us. Look, we're not done yet. We're going to head into the next segment, which everyone loves. Here we go. Tell it to Ed. Ed, as you know, is our producer. He doesn't have a background in child health. We never even give him a heads up about what the topic we're going to talk about is. Bit of a stitch up, yes, we know. But it's a great opportunity for him to ask a question from his perspective. But before he gets to do that, Ros, I'll give you about 60 seconds to summarise this study. And Ed, you have time for one question. So over to you, Ros.
So the REACH study is the largest randomized comparison trial for young babies who will have hemiplegia, showing that there's 2 treatments that will be effective, and support. The important components of it is a very early intervention at the just right level of challenge, and it's delivered by parents.
Beautiful.
That's it in a nutshell.
That's beautiful.
Wow.
I love that.
Very
She's done
short,
this
very
before.
sharp.
Yeah. Just key points. All right, Ed, over to you for a question.
So I feel like my streak of asking reasonably vaguely intelligent questions might be coming to an end.
Oh, Ed.
So I'm just going to caveat this with there are 2 questions here. Perhaps the first one might be a little bit nonsense and maybe the second one might be slightly more serious.
Okay.
I always say there's no such thing as a silly question to my
It's
students,
true.
so don't
Yep.
worry.
Oh, you haven't heard this one yet?
Okay. I'm curious, nervous.
Well, we've obviously been talking today, or you've been talking today, about very, very early intervention. So I'm gathering from the first few months of life. And I think I'm I mean, I'm fully on board with the whole early intervention thing, and I'm really interested to know how the research is kind of working with intervention starting so much earlier, and then this idea of maturation and natural development, whether there's any lag in between that. I don't know if I'm kind of verbalising that particularly well, but if that doesn't make any sense.
I think I get what you're saying. So I guess what we're trying to do, and you're quite right actually, you're probably like a lot of doctors might have said in the past, well, what do you want to do with those babies? Do you want to just play with them? I mean, like, what are you doing there? So, you need to have evidence for what you're doing. So, which is why, many of us have been working for quite some time and what might be effective. But what we need to do is to set up the appropriate environment. So the appropriate environment to optimise learning for a baby who's had an early brain injury, usually during pregnancy, not always at delivery. And so we want that baby to catch up and to optimise what they can do. And that's going to be optimising the parenting skills, optimising the parent's ability to give the just right dose of support and interaction, and to work with the baby to optimise all their abilities. And the area that we're seeing the biggest change is actually the babies with vision impairment.
Right.
And I always say to the parents, this is baby's first skill. So if we can tackle that now, and we're only for the first time picking up babies at 3 months with CVI, they often won't be picked up till much later. And the improvements are really dramatic, and we're going to be presenting some of this in Heidelberg. So plug for going to Heidelberg.
I'll be there. I'll see you.
You're right. You're wanting to sort of catch up on their slope of development because they might plateau early or they might have a slower trajectory. So we're wanting them to maximise that trajectory.
Right.
Okay.
Great. Thank you. Oh, gosh. I said one question. He's put his hand up for a second. I'll allow it. Go on.
Okay.
I'm dying to know.
Oh, are you? Okay. All right. We'll definitely allow it then. The guest says yes.
This is the one that I thought was slightly less tangential. You were talking about lower socioeconomic is the wrong word. Low resource, I think, is what you were talking about.
Low
with other
resource
countries.
settings,
Yeah.
Yep.
So obviously the parents are playing a big part in this particular type of intervention. And so I'm wondering whether there was anything noticed that was different for like parents and caregivers in like higher income countries versus the lower resource ones, and what kind of effect they had on the rehabilitation process, especially at home, I guess.
It's not a bad question. It's pretty good.
Fantastic question.
It's a good question.
Spot on.
Oh, my streak continues.
You're a winner. That is absolutely the point, because we have so many other different challenges. We have parents who have grandparents who say, "Don't feed that baby, let it die."
Oh.
We have faith healers who don't want that baby to live, and sort of a natural selection because it's severely involved. We have parents who they trust doctors, but they have very limited access to doctors. Yeah. Their concept of therapy is that, yes, you take them, you hand the baby over, the therapist does it.
Yeah.
So there's lots of challenges in low resource settings. That's why Kath Benfer's project, working through peer workers who are from the same environment, same level of literacy, same sort of knowledge, can impart that information in a much simpler way and build their confidence. Yes, you can do this.
Yeah.
You could work with your baby. You can see the changes. You can make the difference. And in fact, I find that in many ways when I visit these sites, and I've been to Sri Lanka and Georgia each year and to India many times, it's really encouraging because you can see how much they're changing. I remember going to a little village outside Calcutta. There was one little baby in the middle, and he was in a house. There was 4 families in the one house, the sons with each of their children. So there was about 16 cousins stimulating this baby to do what it needed to do. And the chicken would run through in the middle of the session. And, it was real world early intervention.
Yeah. Wow.
And it was just so effective because they were highly motivated. They understood what to do, but overcoming some of those initial barriers was often a challenge. Yes. And, you have a lot of problems with people moving house all the time, their husband's away.
Yeah.
Unfortunately, domestic violence. There's a lot of challenges in low resource settings that we're not always aware of. But, you know, really, I think shows how that model of the trusted person coming in but building confidence in the parent is the most crucial point of the whole exercise.
Yeah.
Okay.
Great questions.
Really
Thank you.
good question. Thank you, Ed.
Yeah.
Well, that's us for this episode. That was just so wonderful. Thank you so much, Ros, for your time and imparting your knowledge for us today. To all of our listeners, look, I'll put a link, of course, to this paper on our website, researchworks.net. And of course, as always, there's a CPD form there that you can fill out as well if you want to keep this as part of a record of your PD requirements. But for now, thank you so much, Ros. I'll see you in Heidelberg.
Yes, looking forward to it. And we hope to see lots of you in Heidelberg.
Yes.
There's still access to the entry to the conference. It is filling up fast and it might fill up and close. So get in quickly. And we will hope to have a certain proportion, we hope 100% of it hybrid. So we're still working on that for those of you who can't afford to travel.
That's amazing.
So watch this space.
Oh,
Yeah,
good plug. That's really good. Well, to all of our listeners, we'll talk to you all again really soon. Goodbye.
Thank you.